That was a really, really useful overview, I think. But what strikes me from my work with the local authority is that it's actually up to us, in a sense, to do the running. That's how it feels. So just an anecdote to illustrate that. When I have had lots of meetings over the years with the foster care team at the local authority who have been fantastic and very committed to the work. But I remember one meeting particularly that was cancelled time and time again, and eventually when it happened, the person I was meeting was very late and was very apologetic. And she said the reason she was late, they'd had a case conference all morning where they were trying to decide whether two children should be kept where they are in a neglectful situation or brought into care. And if they're going to be brought into care, the only placements they had was to split them up. And, this was a very, very incredibly difficult situation. And I thought, of course my research isn't very high on this person's list of priorities. The real work of the day is elsewhere. And I think, and it really put it into perspective for me, that talking about questionnaires and the methodology was actually low on the list of priorities. So it did feel to me like it's up to us to find the way of making it work. Do you know what I mean?
Yes. Sorry, Val, can you just introduce yourself? I should have prompted you at the beginning to say.
I'm Valerie Dunn. I'm a research associate working under the EDD theme, and I work with children in care and children in transition from mental health services.
I mean, absolutely. I think the message for me here is, firstly, we do need to get over the idea that change in a way that might bring benefit should be informed by research, so that research is necessary. I think there is a cynicism there that, people might look at me and say, well, you would say that, wouldn't you? Because, your job is dependent on that. But we do need to get that message over. But then, as you say, what we need to do is to find ways of doing that are acceptable to those we need to interact with in order to get the data that we need.
Yeah, I think that's right. And I think part of us doing the running is to liaise not just with sort of the managers, but to get into the teams and present the work. And it's a sort of a long, slow process to actually become part of the team if we can. If we're not there physically, we need to. It doesn't always drip through to all of the levels.
Yeah. Jenny, I think, was it someone just behind? Oh, sorry. Yeah.
Mary Ledgard, Health Watch Norfolk. I'm involved with the PPI stream. You talk about government initiatives providing opportunities and the importance of sharing knowledge. Is there a possibility that the initiative to integrate social care and health, hopefully including mental health, present an opportunity to examine what the possibilities are to improve matters?
Yes, that's very interesting. I mean, just to say, in terms of learning disability, we already in Cambridgeshire have an integrated service. It's actually led by the local authority. So I think you're right. I think the first point is that if, as a matter of principle, and I think probably correctly so, integration is good, particularly for this client group, what it then throws up, and what I think our research has identified, and this is across all the different diagnostic groups really, is that in itself throws up new problems that have to be solved. And if you don't address those, then actually you have a dysfunctional bringing together. So I think, first of all, there has to be a recognition that it's a partnership between the local authority and health. That's a bit of a struggle in learning disabilities because the LDP is both a commissioner and a provider. So I think that's an issue. I think often then it is almost very basic things like making certain that you have shared space. And I remember when I'm now speaking as someone who works in the service rather than in a sense from a clerk perspective, that we had to fight because there was an issue about how much will the local authority pay to use space that is actually health authority space. Then there's the issue of computer systems, and then there's the issue of health records. The moment you state this as a principle that you need to work together, then you need to solve the practice. And that, I think, is the big challenge. It ought to be solvable. I mean, in fact, it's not rocket science, but there are things that absolutely get in the way of doing that. Jenny.
This may or may not already have been answered in the last question. I'm Dr. Spencer, Jennifer Spencer from CPFT Learning Disabilities team. I'm the consultant for the team. And I'm also a healthcare fellow in the Engineering Design Center. So like Professor Holland, I straddle the line between clinical care and research, and I'm constantly thinking about both in everything that I do. And therefore, I'm very keen to reduce the barrier to capturing useful data while I'm practicing clinically. And I was wondering yourself how easy it's been or becoming to ensure that record keeping within a clinical organization is designed in such a way that it captures data that intrinsically answers research questions.
Right, right. Now, and that's a very interesting question. I don't know whether, Peter, you have any comments on that. I mean, there is a system within CPFT that seeks to I think, screen mental health records in order to capture research data that was developed at the Institute of Psychiatry in the Maudsley. I have to say, people with learning disabilities have been excluded from that, which troubles me, but that's the way it is. I think that's really important. The problem for us, of course, is that the Health Act allowed for money to be transferred, health money from what were then the PCTs, to the local authority to manage. So our teams are managed by the local authority, and the record system that is kept is now going to be a system agreed by the local authority, although approved for health records. And at the moment, we're trying to influence that to do exactly that. But again, it comes back to the fact that it's quite hard to persuade an organisation that has, many, many problems on its hands that they should do that. But I think we ought to be much more aware of that. And people like Giles Glover in public health are very good at looking at how one might also use existing databases to inform research.
I'm sitting next to Jenny. I'm Emma Weisblatt. I'm a developmental psychiatrist, and I work in the neurodevelopmental service in Peterborough. I just wanted to make a comment, really, and agree with Professor Holland about co-location and the difference it makes, because until a couple of years ago I was a liaison psychiatrist in London, where we were obviously co-located with paediatrics, and everything that you've been saying about co-location, multidisciplinary meetings, communication, joint learning is word for word what the NSF for Children's Mental Health in Hospitals said. And I think there's a huge theme here of integrated working and sharing offices, which is really important. And because Jenny and I work in sort of analogous but slightly different services, we're integrated with community paediatrics in the north, and they're not in the south and the central. And that has its own challenges. We're on a completely different record system from the rest of CPFT, which has pros and cons. But I literally sit in an office with a paediatrician, and that's led us to develop a cost-free new clinic for fetal alcohol syndrome, looked after children, because the person I share the office with is the children in care paediatrician. And we've ended up actually starting, I think, something that fits into the CLAHRC theme, or one of the CLAHRC themes, literally by sitting in an office and discussing children over coffee. And so you can't overstate how important it is that you're in the same building, preferably the same organisation. Sorry, and the caveat to that is that we're incredibly vulnerable to other organisations changing. So we all had, Jenny and I were smiling when you talked about social care, because we all had social workers in our teams. I'm sure you did. Everybody did. Then they were pulled out. We had teachers in our team. They've been pulled out, but they still come and sit in our office, so we still have a relationship. And we're all vulnerable to changes in the third sector, where a sleep clinic will come, it will go, and we have no say over that at all, which just destabilises the whole system.
Yes, I think absolutely. And one message for me about that has been too, I think, that the sort of unintended consequences that happen if a decision is made, say, by the local authority or by the health trust to do something, that if there isn't a mechanism for consultation about how you're going to bring about change, then they do something that really destroys what you've tried to achieve. I mean, we do have care managers, social workers that sit in the teams with specialist health disciplines, and that has been immensely valuable. And we just plead with senior staff that we keep that. But it's fragile. It is fragile.
Thank you.
Marcus.
Yes, Marcus Redley in the EDD theme. I mean, I'm wondering if there's a certain amount of naivety about imagining that research is going to lead to service transformation. Right. In that service transformations are, in many cases, politically driven.
Yes.
And the people who make political decisions choose the research that confirms what they already believe. If you'd like to comment on that.
Thank you, Marcus. Yeah. Now, I think what I can say, having had some involvement with NHS England on this, I mean, in an area that is in the sense, I mean, there's masses of research in learning disability, but actually relatively little that is about services, and I suspect the same will be true in acquired brain injury and so on. That actually, if you have something, and I think a peer-reviewed paper does count here. If you have something that shows the politician and or the civil servants that this is not just a personal view, this is something that has been looked at systematically, has been peer-reviewed and so on. I think the thing they're often battling with, politicians at least, and civil servants on their behalf, is that of course they have stakeholders with competing views. So Isabel and I have sat at meetings where you'll have parents of children, with adult children with learning disability, arguing for something, but they will be arguing for their children, and the politicians will listen to that parent or those parents. And we need to be able, often we can agree with them, but we need to be able to counter that a little bit. But if I try and do it as a personal opinion, it is seen, I think, as the view of a psychiatrist who would say that, wouldn't he? Whereas I think some sort of academic credibility helps to balance that. Maybe that's naive. I would like to think we can influence things.